All right. Hello, my name is Dr. Dominic Chow. I'm one of the faculty members here at the John A. Burns School of Medicine. And I thank the organizers of the mini medical school for providing me an opportunity to talk about a growing epidemic, the long-term manifestations of COVID disease, what we commonly refer to as long COVID. My objectives today is to provide you a discussion on the magnitude of post-acute sequelae of COVID-19, or PASC, or as I mentioned, what we commonly refer to as long COVID, provide you information in regards to symptoms, information in terms of the definition, possible mechanisms, appreciate the pulmonary, cardiac, and neurological and psychiatric complications that commonly occur in this condition, as well as potential treatments, as well as public health implications. I hope I have no financial disclosures for this talk. So here, in this slide, the next epidemic that we will be seeing is long COVID. And the reason why I was mentioning that this is the next epidemic is that the individuals who have had COVID infections, 10 to 40% of all those individuals will develop the condition called long COVID. The duration is unknown, and there's a high degree of disability. Many of you have seen celebrities. I think just this past week, there were multiple celebrities who came out reporting long COVID. Alyssa Milano, here you could see she's on oxygen therapy. Lena Dern, she reports having swollen hands and feet and increasing migraines. And here in Hawaii, you could see that our State Senator Kalani English had to resign from his duties in the legislature because of difficulty with long COVID. He had reported having lots of fatigue and also brain fog. So when in whole, there are estimated to be more than 100 million people worldwide to have long COVID. The symptoms of long COVID are depicted in this cartoon, where you could see how you could see the various types of symptoms that one could have. The circles represent the frequency, and so you could see that neurocognitive disorders, such as brain fog, is quite common, concentration impairment. Neuropsych conditions, primarily anxiety and depression, sleep disorders, or as you can see also in this blue. And then cardiopulmonary conditions, chest pain, shortness of breath, are also very common. Fatigue, systematic fevers, and less commonly neurologic, musculoskeletal, gastrointestinal, and other symptoms are also very common. I think in this slide you could see that compared to acute COVID, you could see that for long COVID, majority of individuals will have symptoms of fatigue, dyspnea, which is shortness of breath, and joint pain, chest pain, and cough. These tend to be the more common symptoms compared to the more variable in multi-symptoms in acute COVID. This graph shows the comparison of acute versus post-acute or long COVID in the durations. So we tend to think of acute COVID as lasting from 1 to up to 4 weeks in duration. Subsequently, after 4 weeks, it becomes long COVID. And then within long COVID itself, there are some differences between subacute ongoing COVID versus chronic COVID. And so in one of your handouts, you will have seen that there are 3 types of long COVID. There is more of the subacute than chronic, and then there are individuals who are long COVID due to post-hospitalization, more likely from mechanical ventilation. That kind of creates a whole different sort of symptoms as you require mechanical ventilation to keep someone alive, and those can have long-term repercussions. You can see that the SARS-CoV virus can last quite long in the nasopharyngeal cavity. And we're suspecting that that might actually be even longer than 12 weeks. Within the typical, more deeper collection of viral isolates of the deeper lungs or the lower lungs, that tends to be actually short-lived and disappear by 2 weeks of catching COVID. And you can see that we just talked about all the symptoms that can occur. So the WHO, the World Health Organization, released the official long COVID definition several weeks ago. And it is quite vague. You could see that the post-COVID conditions occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID symptoms and lasting for at least 2 months, and cannot be explained by alternative diagnoses. Common symptoms occur fatigue, shortness of breath, cognitive dysfunction, and others, and generally impact everyday function. So again, you could see that these symptoms can be quite vague, but are, no doubt about it, has implications to the welfare of our patients and is a true condition. I don't want to discount what patients say. Lots of patients are feeling isolated already, and we should be as supportive as possible. You could see here that there's a likely relationship between organ dysfunction and persistence of symptoms. And you can see that acute COVID symptoms, you can have people who are asymptomatic, mild, moderate, severe, and critically ill. And you could see from here, they could develop post-acute COVID, where this multi-inflammatory syndrome condition persists, creating organ dysfunction and persistent symptoms. And I just want to highlight on this slide that these individuals who have asymptomatic infection can go on to developing post-COVID or long COVID conditions. And so I think what's fascinating is that there is potential mechanisms for long COVID. As I mentioned, after the acute COVID infection, one can develop mechanisms where it may persist beyond the acute phase to more of a long COVID stage. And that the mechanisms can be of multifold, given that there are so many symptoms. Perhaps there could be a combination of all these effects, or maybe just one of these, depending on what the symptoms of these patients are. So I'll just outline them. Well, we currently believe that there are autoantibodies. These are antibodies our body creates, a kind of glue that kind of protects individuals against bacterial infections, parasitic infections, but it can also change and become rheumatologic disorders, autoimmune disorders that have implications in which these antibodies in our bodies fights its own self. And so autoantibodies have been found in multiple longitudinal studies and can be responsible for some of the symptoms. Many patients may see patients who, or have relatives who have rheumatologic disorders like lupus or Sjogren's, and some of the symptoms can be very similar to that. And so that's where the autoantibodies mechanisms comes in. Another possibility is that of post-viral transcripts. So one of the factors is after being infected by COVID, that there are viral remnants or particles in the body that need to be removed. And because it's still floating in the bloodstream, it causes some havoc within our organ system. It can lead to something in terms of inflammation, where there are increased inflammatory cytokines. You may have heard of things such as cytokine and cytokine storm. And that may have some detrimental effects on overall on an organ system. And then there's this whole issue of viral latency, where very similar to HIV. It's not the same type of virus, but similar to other viruses such as HIV, the virus persists in the body and creates ongoing infections. Now the levels are low, and so it may not be found on commercially available SARS-CoV tests, the ones that you do a nasal test on, but it still may be present in the lower or upper nasal pharyngeal cavities itself, and continues to have persistent infection. And then of great interest to our group has been monocyte activation. Because SARS-CoV can activate certain cells in your body, these monocytes may then be persistent and cause some undue effects on the rest of the body. And lastly, the issue of microclots has been more investigated in Europe where clots occur due to SARS-CoV causing thromboses, more stickiness of the endothelial layer causing clots, and these clots can actually form and have clots in the neurologic system as well as heart and lungs, and may be responsible for that. And so our colleagues in Germany have actually done apheresis, a type of intervention in which it's very similar to hemodialysis, where they'll actually filter the blood and have found clots in the body. And may be a source of why long COVID occurs. And so many of you have heard of some of our elite athletes having heart conditions subsequent to COVID infections, and myocarditis or infection of the heart, cardiomyopathy, which is congestive heart failure, the heart that gets enlarged. Myocardial infarctions or acute heart attacks have been shown to occur, although not as frequently. Arrhythmias, cardiac arrest, and then thromboembolic events, kind of what we just talked about in terms of the clots. And then we have certain biomarkers that have been linked to poor prognosis, such as troponin and BNP. These are peptides and biomarkers that we often obtain in our cardiology clinic. At the first stages of acute COVID, many of you may have heard or seen in the news about these elite athletes having carditis, and you could see from this cardiac MRI scan showing COVID effects on the heart muscle. Almost 50% had evidence of myocarditis, and again, these are very healthy athletes. In COVID having its effect on these individuals. The long-term issues of carditis is unclear. Thankfully, most of those repeated cardiac MRIs did not show ongoing inflammation or infection of the heart. In terms of pulmonary complications, almost 83% will have ongoing consolidation and ongoing effects in even asymptomatic and symptomatic individuals. Many of you have also recalled that the Diamond Princess cruise line, there were many individuals, over again 50% will have lung findings even though they were asymptomatic. In terms of neurologic conditions, we see in our clinic headaches and seizures and ischemic strokes for the acute phases, but many of our patients will still have some ongoing cognitive dysfunction, the brain fog that many people will talk about in the news. And then some of these are less likely to occur. Just a little bit on the olfactory gustatory dysfunction or the loss of taste and smell. Those can actually occur for several months on end. But thankfully, majority of those individuals all get better. Psychiatric-wise complications, depression, more so of anxiety, fatigue, post-traumatic stress disorder, especially if they've been hospitalized, and then connection with the neurocognitive issues of brain fog. And these long haulers will often complain about having difficulty getting out of bed and being able to perform their usual activities. Activities of daily living will be compromised. And then the thromboembolic complications, we've seen a fair number of individuals with pulmonary embolism, DVTs. These are clots within the blood system that can again cause issues within organ damage. And it's quite high among people with acute COVID. It's about 20 to 30% in many studies. And so long COVID have shown that the biomarkers, many of them continue to be abnormal even months on end. And so you could see that in this, those discharged will have persistence in this D-dimer and C-reactive protein. These, again, are biomarkers that just show that there's high levels of inflammation going on in the body. And again, about 38% will have chest X-ray findings. As a primary care physician, we need to be cognizant of our patient and not to discount our patient's symptoms. I think our patients are already feeling isolated from society, due to the lockdown and quarantine of these individuals. They're already feeling quite lonely, and their whole social network has been disrupted. As a primary care physician, our duty is to try to help them, guide them through these symptoms. Currently, there's no current guidelines on treatment. Very similar to the HIV epidemic that occurred 40 years ago. We're at the very beginning stages of this epidemic, and again, there is no therapy for long COVID. Our duty as primary care physicians is to try to actually identify kind of the 4 areas of focus, which I will actually talk about in the next slides. So you could see here, managing comorbidities is very important. Individuals who have higher comorbidities have higher rates of long COVID. And by controlling diabetes, cardiovascular disease, hypertension, and lung diseases will actually help mitigate how severe long COVID symptoms occur. And in terms of investigations, we'll often do these biomarkers that I just talked about in the prior slides, where it can help us kind of determine what the prognosis of these individuals will be, and perhaps offer maybe some avenues of treatment. Getting chest X-rays, urine, EKGs will also be important. And then kind of helping individuals with their social, financial, and cultural support. And here I think as a primary care physician, we could do a lot of good in our patients in that, again, patients are feeling isolated. We can help them with reestablishing their social networks, providing them with support groups, helping them through their times of financial stress. Many of these individuals cannot work, and so helping them with their disability claims will be important. And then providing some cultural aspect or social support will also be very important. Providing the safety net referrals are important. Providing referrals for respiratory, cardiac, and neurological subspecialties is important. And then helping them with dieting, sleep, quitting smoking, limiting alcohol, and then caffeine, and then kind of overall looking at the overall mental health will be important. And so post-COVID care clinics have been popping up throughout the country. And you could see that by far the focus have been cardiopulmonary, but not limited to this. We could see that neuropsychiatric subspecialties are also involved, hematologic as well as renal. And then our role in the primary care is to be gatekeepers as well as the source of where we could refer patients and be an ear to our patients. At Queens Medical Center, we have a paradigm in which we have 4 focus areas: clinical, research, education, and then occupation and student health services. And you can see we provide lots of clinical care to our patients in terms of post-COVID care and advocacy. Research-wise, again, this is only the second year of this pandemic. A lot is not known, and we could help the nation as well as our own center with determining what are the guidelines of treatment of long COVID. Educations like these into the communities, as well as teaching our medical students and residents and colleagues will be important. And then occupational student health services are also a tenet of ours. Occupational, when to go back to work, as well as when students can actually participate in varsity sports will be important. And so we have some local studies at Queens where we're looking at the seroprevalence study. We received a generous grant from the Angus Foundation. We're working with, in terms of a type of medication called temosartan. It's an ARB, angiotensin receptor blocker medication, similar to losartan for some of you who may be taking this, in reducing lung and cardiac long-term complications. And one last note, we just were notified that we are part of the Recover Cohort Network, and this is a network of NIH academic institutions, and we hope to be among these leaders in finding the next medications as treatments and understanding of the overall mechanisms of COVID and long COVID. And it's an honor to be part of one of these 12 large academic sites. And I have to say that this is the Queens paradigm. There are other medical institutions that have similar paradigms, so it isn't unique to Queens. I do know that Hawaii Pacific Health, they also have a post-COVID care clinic, and very similar in its overall approach. So if you were to come to our clinic, the post-COVID care clinic at Queens, you would be registered in, get vital signs, get a COVID questionnaire to try to determine what are the social determinants of long COVID, and then go on to and do a questionnaire on physical activities. How active and how much has long COVID impacted activities of daily living? There is a patient health questionnaire on depression question. In this questionnaire is the PHQ-9, which many of you possibly have filled out on your own visits to primary care, and that looks at depression. We also do a general anxiety disorder or the GAD questionnaire, and that looks at anxiety. We also go on and do a cognitive assessment, MOCA, which has been validated as a good screening tool for neurocognitive impairment. And then we look at frailty, we do a physical exam. We'll also look at doing a thorough neurologic examination to make sure that there is no evidence of prior stroke. And then we do a neurologic assessment to look at peripheral neuropathy, weakness, and reflexes. And then we do a 6-minute walk test. It is a rather easy test, low fuss test where we'll walk the patient for a total of 6 minutes and determine the distance. And we know from normative data that we could then see how much of an impact long COVID has had. And this test is, although rather simple to do, has yielded a lot of information about patients, how much of an oxygen desaturation, if there's blood pressure fluctuations, can occur during this test itself. And so this allows us to provide a gateway towards other specialty services like cardiology, neurology, or pulmonary services. We then, depending on what the patient has in terms of symptoms, may get a chest x-ray, pulmonary function test, ECG, and echo, and then you could see that we then do a thorough investigation of the blood in terms of biomarkers, inflammatory markers, and thrombotic markers, just to see what may be underlying issues among our patients. And so I do have some data from our own clinic. We've already had about 200 individuals since the beginning of this year at our post-COVID care clinic. And you can see by far it's has affected disproportionately more of the Polynesians. We have an older group of individuals. Many have been hospitalized. Many also have required oxygen at discharge of almost 22%. And then lots of comorbid conditions. And then 17% has had pulmonary embolism. And 3 people have had reinfections with COVID, even after the first incidence of having a COVID infection. And then clinical examinations findings, many have anxiety, as you can see, and then also depression, lots of neurocognitive issues requiring referral to neurology, and then a quarter of them will have some abnormal 6-minute walk test. By pulmonary function test, that's a test of where you blow out a tube and you could actually look at lung volumes as well as restrictive as obstructive lung issues, and you could see that 80% of those individuals who had some complaints of shortness of breath went on to getting this pulmonary function test will have pulmonary findings on the pulmonary function test. And then very similar to the data that I presented earlier, inflammatory markers are elevated in our patients, many of which are 2 months out from their initial COVID infection. And so our clinic is not any different from, say, if you were to see your primary care physician, but we would have a easier, I think, avenue of referrals to cardiology, pulmonary neuropsych, and other specialty services. And compared to primary care, we may identify things a little bit earlier due to we have a lot more time afforded to seeing our patients. And again, we do some of those tests that we normally may not do in your general medical examination, such as the MOCA test and the 6-minute walk test. And then of great interest to many of my colleagues is what do you do when you've diagnose someone with long COVID? Well, the current therapies that we know that work are exercise, but the exercise should not be exhaustive, meaning that we know that people who go beyond 80% of the maximal heart rate, they actually feel worse. This may be due to overexertion or over-fatigue or overtaxing the body. So we want people to exercise, but at a pace where they are sweating, they may be a little short of breath, they may not be able to talk very well or sing very well, but we don't want them to be completely exhausted. We know that improving sleep helps. We know that the COVID vaccine also helps. If you recall, there is a potential of mechanism of long COVID as being from viral latency, where there's ongoing virus in the body. By giving a vaccine, it may help your body identify the virus and finally get rid of it or expunge it or eliminate it from the body as completely, and therefore people will feel much better. And so just again, to emphasize the importance of vaccines, the vaccines in I think in patients who have not been vaccinated in our clinic, a quarter of them after receiving the COVID vaccine will feel much better, and a lot of the long COVID symptoms will resolve. And so it doesn't occur and benefit all our patients, but there is a role for COVID vaccines in treatment of long COVID. SSRIs such as Prozac, Paxil, Zoloft have been used successfully in helping patients cope with overall fatigue and chronic fatigue syndrome. Counseling helps patients as well as aspirin and statin therapy. And we think that aspirin and statin therapies may help eliminate some of these viral transcripts in the body. Recall that these are the viral remnants in the bloodstream. Aspirin and statins may actually wash away some of these viral particles, help eliminate it at least from the body, and therefore help reduce the long COVID symptoms. What's unclear are the following, and I would advise not using these medications for the treatment of long COVID, as they could have high side effects. So hydroxychloroquine, a medication that we use for rheumatologic disorders as well as for malaria, has been studied extensively for acute COVID. It doesn't have any role in acute COVID, and it doesn't have any role in long COVID at this time. Ivermectin, which is a parasitic a medication used for parasitic infections, has received a lot of press in terms of acute COVID. It has no place currently in acute COVID, and nor does it have a place currently in long COVID treatment. Maravirac, a medication that is used extensively in HIV, helps with the monocyte issue. It also has no current role in long COVID. I know that there are some studies of ivermectin and maravirac, but those studies have not yet demonstrated any benefit. And then there are some who provide high-dose iodine, vitamin A, D, and E, and hydrogen peroxide, in which they consume these or intake these medications, and it has no, place again in long COVID. In regards to current therapies in pulmonary disease, exercise, deep breathing, oxygen supplementation has been found to be beneficial. Inhaled corticosteroids, along with beta agonist and muscarinic agonist, or LAMA. You may have heard of things such as Symbicort or Wexela or Advair. These are inhaled inhalers that seem to benefit or reduce some of the inflammation and help with the long-term shortness of breath, dyspnea, or exertion for our patients. And then there are these angiotensin-converting enzymes, or ACE inhibitors, and angiotensin II receptor blockers, or ARBs. This is like lisinopril or losartan. These have also been studied, and in the acute COVID has been shown to reduce COVID pulmonary and cardiac complications, and has also been shown to be somewhat beneficial in long COVID. Oral steroids is a little bit, has been studied, but also has been shown to be a little bit cautious about long-term use because of the side effects. It does help our patients, but I'm not sure how it plays out in long COVID. In terms of herbal supplements, there's a whole mix of medication supplements that have had some benefits. I think no one herbal supplements have stood out in terms of benefit, in terms of long COVID. And we've had some success with the Tamasartan study here in Hawaii. We're looking at long-term pulmonary and cardiac complications. Our data is not out yet, but in a larger study, they found fewer deaths in hospitalized COVID patients on ACE and ARBs. Again, this is with acute COVID, but not necessarily with long COVID. We're currently doing studies to look at the benefits for long COVID. And in terms of brain fog or neurocognitive effects or impairment. We do know that stimulants as well as cog rehab may have some role, but I think cog rehab has been by far the most successful, getting people to do like brain games, such as Lumosity, getting people to do checklists are also important, and then to exercise and to read and do more interactive activities rather than doing activities such as like watching TV or where there's no interactive effects with what you have to do. So anxiety, there's counseling. We provide a lot of patients with SSRIs, and that's our mainstay at our post-COVID care clinic. Benzodiazepines can be offered, although we also are cautious about the long-term side effects. Medical marijuana and cannabinoids like CBD oil, there are some studies looking at that, and nothing has been definitive as of today. Many of you may have heard about this ongoing syndrome that's called postural orthostatic tachycardia syndrome, or POTS. And this is a autonomic disorder in which there's a dysregulation of homeostasis. And so I think how to kind of explain POTS is that when I, say from a normal person, go from a lying to a standing position, our heart rate speeds up a little bit, our blood pressure initially falls a little bit but goes back up, and we make these incremental changes that or instantaneous as activities of daily living, as you get out from your bed to standing position. People with POTS have an overshoot where there's a lot more fast heart rate, where we talk about tachycardia, and there may be some drop in the blood pressure, and because of this dysregulation, individuals will have more catecholamine release, adrenaline, which many of you have heard of, would actually make people exhausted. And so this exhaustion leads to a lot of symptoms associated with POTS. And unfortunately, the only therapies that seems to be work is exercise, or rehydration, and then increasing salt. And then some of these other therapies are been helpful, but not been shown in terms of help and benefit in all patients. And then there's a lot of interest in whether or not aspirin or the use of like Eliquis or apixaban may actually be helpful in reducing those microclots. I think more needs to be seen. And the apheresis machine that I talked about earlier, where you get it's similar to hemodialysis, have been used in Europe. And then in terms of loss of smell and taste, there's cog rehab, where they'll use essential oils and foods where you'll taste it and you'll repeat yourself afterwards. This is like, if you were to consume a lemon, say, this is a lemon, this is a lemon, this is a lemon, and kind of reorientate your bodies in terms of certain tastes and smells. And remedies that are not recommended, like things like ginkgoba, ginseng, garlic, ephedra, all of these have side effects that are not beneficial in terms of long COVID. And then in terms of antivirals, a lot has been seen recently with the Pfizer antiviral and Merck. We're waiting for these to be available, and we may start using this in our post-COVID care clinic to see if we could actually help our patients with their symptoms. And then I won't go into it, but there are these mast cell inhibitors that help with inflammation, and inhaled temosartan. These are things that here at the John A. Burns School of Medicine we're actively looking at. And so the public health implications are quite large. The healthcare burden is going to be huge because of, again, 10 to 40% of all people who have had COVID infection will have an increased healthcare burden. The long-term disability of the patients will be immense because a lot of them will not be able to work. The psychological burden is also devastating, and then again, the financial burden as a society will be quite large. By far, I can't say enough about prevention, and you could see here depicted on this graph our entire approach to COVID care at Queens would be prevention, early infection, late, and then post-infection, and then research, which kind of traverses all the areas of focus. By far, our efforts have been primarily of prevention, getting vaccinations, using face masks, social distancing. We know that these activities work, and we know that this is the best way of preventing from catching COVID in the first place. By not catching COVID, your risk will be zero in terms of long COVID, and not have to have that extra burden. But you could see that we do have early stages of having a hotline, a transitional care team. If one gets hospitalized, the hospitals team takes over, and then heaven forbid if people need critical care. And then our last of all is really kind of picking up some of the pieces of post-COVID care. And so this is our flyer for our post-COVID care clinic, very similar to, again, the ones that are seen at other medical institutions where we do a holistic approach of looking at heart, lung, brain, mental health, and then joint and muscular diseases. This is our hotline. We take referrals primarily for primary care physicians. If you have friends and families, members who you suspect may have long COVID, we would want to help out in terms of providing you with education and also care if needed. And so with that, I'd like to thank you again for helping provide more information about this epidemic that we see is up on the horizon. So thank you.